would like to welcome you to today's webinar on the topic of demystifying kidney pair donation from a clinical and administrative perspective. We have a great webinar for you today, and just before we get started, there's a couple of housekeeping items to go over. Just to help you understand this webinar platform and how you can use it more effectively, if you're having any audio issues, you can either dial in on the phone number that was provided in the email that you received. Also to the top left, you will see a little wheel icon. And if you click on that wheel icon, you can also check out your audio settings. Then in the bottom left-hand corner, you will see a chat box, a blue chat icon. That's where you can submit your questions for the speakers, and you can submit those at any time, and we will be holding them until the end, and we'll pose them to the speakers at that time. Also to the top right, you have to be aware there's actually two little icons. The one that looks like a little box, like a little square. If you click on that, you can see the slides in full screen mode. I wanted to share that on February 10th, we have a complimentary webinar coming up on the Alliance 101. And that's just an opportunity for anybody who wants to get to know us at the Alliance a little bit more and understand our history and what we provide and where we're going from here. So you may register for this on our website. And then also on February 14th, we have our next donation-focused webinar on the topic of supporting children through the donation process. And that will be an excellent webinar as well, and registration is open for that as well. For today's webinar, we are providing one CEPTC credit. In order to obtain the CEPTC credit, you need to complete the evaluation within 30 days from today. And so within the next 24 hours or so, the person who registered for this webinar will be receiving the evaluation link. So if you are hosting a group of people in a room, please make sure to take note of everybody who is in the room and forward the evaluation link to them, and everybody will be able to receive their CEPTC credits. This also applies for nursing contact hours. There's 1.2 nursing contact hours. We want to thank Iowa Donor Network for sponsoring those. And please note that the turnaround time for the nursing contact hours is 14 days, and that's 14 actual days, not business days. At this stage, I would like to introduce our moderator for today. Our moderator is Debbie Mast. She is a member of our Transplant Webinar faculty and also our Transplant Leadership Council. Debbie is a financial data manager at the Solid Organ Transplant Program at Stanford in California. Debbie, thank you very much for organizing today's webinar.
Thank you, Hetty, and welcome everybody. Glad that you joined us today. I would like to introduce our two speakers today. Our first speaker is Andrea Tejan, and she is the Director of Transplant Data and Finance at St. Barnabas Health. Since 1999, she's managed all transplant finance, data, and quality activities, including financial and operational reporting, billing, regulatory compliance, contracting, budget preparation, and research funding. She's a member of various organizations in her field and serves on committees including the National Kidney Registry Financial Board and the UNOS Kidney Pair Donation Financial Subcommittee. She received her BA from Douglas College, a BS from Uppsala College, and an MBA from Regis University, and a Six Sigma Green Belt from Purdue University. She served as an adjunct instructor in accounting since 1996 for graduate and undergraduate students. She's also a State of New Jersey registered certified public accountant. Andrea is also the author or co-author of nearly 50 publications, presentations, and papers in her field. Excuse me. Our second speaker is Marie Morgevich. Joining St. Barnabas in 2003, Marie oversees patient care and clinical aspects, as well as administrative responsibilities related to the division's pre- and post-transplant departments, the Transplant Short Stay Unit, and the Living Donor Institute. The Living Donor Institute offers paired exchange, compatible share, altruistic donation, and a program for incompatible transplant. She serves on the medical board of the National Kidney Registry, as well as other national committees pertaining to living donation. She also publishes and presents nationally on topics related to living donation. Marie is a transplant nurse practitioner and completed her Master of Science in Nursing at Columbia University School of Nursing, New York, and her Bachelor of Science in Nursing at Seton Hall University, New Jersey. She also holds a business degree from Montclair State University. Please join me in welcoming our speakers today. Andrea?
Thank you, Debbie. So the first part of this presentation, I'm going to speak about what centers need to know about KPD administration and finances. And I would like to start out with just saying that this is not only experience from my center, but essentially a compilation of best practices from many centers throughout the country, and many of those that are even alliance partners. So the first thing I believe centers should really do is understand that this is a team effort. And with all new efforts, you need to map out your flow. Centers should look to see what happens and when it happens, and look for triggers or weaknesses in that flow. And I'm going to show you a flow sheet in the next slide. But the other important thing to do is when you're initiating KPD is meet with your hospital's administration and finance. There are a lot of moving parts that we will discuss in detail, specific to how do you bill for donors, how to post receipts for donor invoices, how this will affect your Medicare cost reporting, and even contracting. So these are critical elements that many within the transplant department may not know about, but those team leaders in administration and finance at your hospital will, and they can assist you to making sure that you're doing things effectively, correctly, and compliantly. So here's an example of our flow sheet, and this is our living donor flow. And what's important from this flow is not so much the steps, but to understand who is doing what. So what the transplant coordinator is going to be completing, what the financial coordinator is going to be completing, what the social worker is going to be doing, what the donor advocate is going to be doing. When you map out all your parts, you will be sure to include all of the requirements to make sure that you're not missing any steps that are part of your policy, part of your process, and ensuring that you deliver the best care that you can, again, compliantly and appropriately. So you need to start at the beginning of your flow. And as with most processes, there's a multidisciplinary process. Look at the review for both your patient and donor. We start very early on is if a patient presents to us and we are looking right away to see if KPD is an option. And this should be done before the patient is properly even approached or educated. So sometimes you can present to them that this could be an option, but you want to make sure that you're doing some steps in advance. For example, if the patient was determined to be incompatible, you don't want to then say, let's go to KPD if there's an insurance issue. So you want to make sure that you're doing two things. Number one, making sure that patients that come to your center through your literature and through your generalized education know that KPD is an option at your center. But when you're speaking specifically about patients, you want to make sure that before you provide them with that very detailed information, make sure that you have all the information up front so you could properly educate your patient. So when we talk about the financial assessment for KPD, it's slightly different. The first thing you want to remember is that you should always evaluate your pairs as you would for any potential living donation. And then as required, there's KPD-specific consent and education. You might want to consider putting some specific information with respect to finances. So for example, when you are doing KPD finances and you're exchanging donors and donor information, you want to make sure that you have policies and processes in place to be confidential, but that may not always occur. So you want to ensure that you're properly educating your pair as to what's going to happen when you're exchanging. That might be different than your standard paired through the living donation. You also want to make sure that when you're doing your assessment, you include all the psychosocial aspects that actually go hand in hand with financial assessment. So their ability to maintain health insurance perhaps, ability to pay premiums and copays, short and long term, look at their family and social support, Are there any other financial stressors, and any past and present social history, any red flags? So we want to ensure that we are not treating this any differently than we normally would, and we're actually on a higher alert to make sure that we're not setting ourselves up to have anything that we've overlooked. When we clear our recipient for KPD, this must occur at multiple time points. So in many cases, when we're doing a standard living donation at our center, we would evaluate the pair at the time of evaluation and then possibly prior to the actual donation. But when it comes to KPD, this timeline may be different. So the first thing you want to do is you want to evaluate your financial clearance prior to consideration for exchange. Then you're going to actually confirm it at the time of registry or exchange entry. You also then would want to look at it at the time of match because it could have changed, and then prior to actually scheduling the transplant. So this timeline could be very different for KPD. When you have individuals potentially that are highly sensitized, they could go through a number of matches and they could wait a long time on the registry. And as a result, we know that insurances can change. Insurance coverage can change. Elements of the policy can change. So we want to be sure that at every given time that we are actually looking at this so that we're not missing an opportunity to educate and clear appropriately our patients and making sure that both our recipient and our donor are covered. So we also want to make sure that not only does our recipient have coverage for donor providers from another state, we want to inquire, is there a global agreement in place? So a global agreement sometimes is an agreement with an insurance company in which a transplant center gets a lump sum payment, and that payment represents costs for the actual transplant and the living donor, wherever that donor may be. So if that is the case and you're working with another center with one of these contracts, how would that work? And what is the plan for coverage for donor complications? So are there limits? Sometimes there are 30-day or 90-day limits. Sometimes there are co-pays and deductibles. So we tend to look at these things when we're doing a standard living donor at our center, but when it's a spouse to a spouse, or it's a husband to a wife, or a mother to a daughter or a child, we know that they're committed. Here we have an anonymous relationship. So we have a fiscal duty to make sure that we are protecting all parties involved. So making sure that we know these elements up front are important so we can communicate them to the centers. When we're financially clearing our donor, we want to ensure that our donor is covered by whomever the recipient they are matched with. And again, is there a global insurance contract in place? And what is that coverage for donor complications? Also, what is the procedure? So if my donor here in New Jersey is experiencing a complication, how am I going to be billing another recipient out of state or at another center? So I need to be able to understand how to communicate that and how to execute that if in fact that happens. So I'll talk a little bit about the specifics of that, but those are elements that you want to ensure that you're screening for up front when you're performing your financial clearance. So I'm going to show you a series of slides that are tools that our system has developed, and if anyone is interested in having those, you can certainly reach out to me and I'll be happy to share them. But we created tools that help us track what is needed and how it's completed. So this is a screenshot of when we're clearing our financial recipient and donor. And so you will notice just kind of on the far right-hand side, we have boxes for the recipient center and the donor center. So we can track to see all the steps that we've done and all the steps that the donor center has done. And again, this just helps us, especially on the upfront when you're first doing these exchanges, to kind of guide you and walk you through so that you're not missing any steps. We also use specialized tools so that we know if there's travel benefits involved, for example, just for a standard living donor, and then what is the donor coverage. So these are just in particular to living donation, and then donor coverage is applicable to both living donor and KPD. So we can understand these benefits up front. We also spend a lot of time creating templates so that our recipients are well educated. So this is an example of transplant financial information that is written at a 5th grade level that our transplant recipients get. And so we have to be certain that as we've assessed them, that they truly understand, regardless of who their donor is, what their responsibility is. And on the next page of this, you'll see that we talk about the living donor cost very specifically. And so we can articulate to our recipient, and again, that's when we talk about having a hand-in-hand process with our psychosocial process, is that we're sure that we've properly assessed and educated our recipient, and that we're sure that the recipient understands and confirms their understanding of what their coverage and or risks of coverage are going forward. So there was an MLN Matters distribution of, I think this was back in April of 2012, and CMS actually put out this clarification on who pays for donor complications. And this speaks specifically for Medicare recipients. And essentially, you're free to look this up. This is readily available on the web. But from a Medicare perspective, Medicare is very clear that if the recipient has Medicare at the time of transplant, that the donor will have coverage for complications lifelong, as long as, again, it is attributable to the donation, and that might be requiring medical documentation. So, for example, if you have a recipient today that is enrolled in Medicare and we have a donor that donates, that Medicare can expire in several years or drop their Part B coverage, irregardless, as long as the recipient had Medicare at the time of transplant, the Medicare complications for the donor would be covered by Medicare. So many centers are, kind of clued into understanding if the recipient has Medicare or is Medicare eligible, and has to appropriately educate the recipient and donor of that. So if you have, for example, a pair where the recipient is not Medicare eligible and you have this information referenced, you want to make sure that first you speak to your donor about what the recipient's limitations of coverage are. For example, if they're not Medicare eligible, what their current coverage is, and then again assessing what is the recipient's responsibility to pay those donor complications long term. Now, I will just mention here that many centers have a specific policy, or a commitment rather, to cover donor complications regardless. What you just need to know specifically is that you need to straighten this out and be clear on your center's process in advance for KPD, because again, this is going to concern a donor that may or may not be at your center. So just to wrap up, for donor complications, you want to assess, you want to educate, and be sure that you know who is going to pay, when the coverage ends, and how are claims to be submitted if in fact donor complications are experienced. So let's talk a little bit about the difference between assessment and financial clearance. So we need to assess objectively, but we need to advocate for our patients subjectively. So once a patient is cleared clinically and financially, there still may financial barriers, and we want to ensure that we're fighting for our patients. And so the reason why I put this slide in is because we don't want to, KPD is becoming more and more acceptable. We don't want to come against something that we think is not covered. And for example, say if you have a matched pair and they're out of network, can we make an agreement? So you have a donor here in New Jersey and a recipient in California, and our donor providers are not in network with the California insurance. So is there a way that we can overcome that? And then similarly, are there coverage gaps for the recipient? And so can we look to the NDLAC, for example, for assistance? So those are the types of things that we want to make sure that we just don't hit a barrier and then move away from KPD. As it becomes increasingly more acceptable and more common, we have case managers that are more familiar and more readily available to help us with some of these things. So you've entered your pair into the registry, and now what happens? So once you get a match officer, again, you want to follow your process and make sure that you're ensuring that there's financial clearance. The next step we're going to talk about is there an agreement in place between the center that you're matching with? So for the National Kidney Registry, the agreement is part of participation. So there are agreement considerations. You agree to those up front. Once you are in the registry, it's implicit, and so the agreement has reciprocity, and for every exchange that you're in, that agreement exists. And there are specific guidelines and there are specific instructions on how to execute that agreement and all the billing. For the Alliance for Pair Donation, they currently have a pilot SAC going on, and there's, again, agreement for participation. For UNOS, there's an agreement that is needed. So for the UNOS paired exchange, just because you're in the UNOS paired exchange, an agreement does not exist between the centers. And so you do need an agreement. That agreement needs to specify the summary of exchange between the parties, so what centers are exchanging, what are the regulatory requirements that you're going to be following. Most likely they will be the CMS standards. You want to speak to HIPAA compliance, indemnification, what happens if there's a problem with the donor kidney, financial agreement for billing, and then legal notice. So let's take a closer look at some of these elements. So here's just some screenshots that I'm going to cycle through. Again, this is a boilerplate template that I'm willing to share with anyone. Most centers in UNOS have an agreement. So if you are participating in UNOS for the first time and you are in an exchange with another center, ask them. They may readily already have an agreement that they can send to you. So this kind of talks about specifically the description of services in exchange. Who's going to be exchanging to whom? Then we talk about the representations and the warranties, which is the legal language to really ensure that we're following Medicare and CMS guidelines. We talk about all the requirements for KPD in terms of informed consent, validation of blood type, etc. Those, again, are part of the UNOS policies. There's going to be a section about how we're going to bill for this. So how does the donor hospital bill the recipient hospital? And specifically, we're going to talk about what those recommendations are, what methodology we're going to be following, etc. And this, again, is just the specific obligations and what would happen in the event that there were complications. So specifying these things up front protects not only your patients, but also your organization and your facility. So many centers and many of the exchanges, such as National Kidney Registry, are using Departmental Charges method, and that's the method that CMS has somewhat blessed. And essentially, you're going to take the bill or the UB04 for your donor, and then you ask your finance people for your Medicare cost worksheet. It's also called the D4 worksheet, and essentially you reduce all of the charges to cost. And what Medicare has clarified for us is that when you're doing a KPD exchange, in essence, all of the charges for the donor go to the recipient after the time of match. And I'm going to show you that there was a recent clarification that came out from that. So essentially, you're going to be taking the charges for the donor nephrectomy inpatient for your hospital, reducing that to cost, taking that cost off your cost report and sending it to the recipient center, and they add that onto their cost report. And then similarly, if your recipient is getting a donor from somewhere else, you will be receiving an invoice for the donor kidney that your recipient has received. So here's an example of the UB04. This is an example of a Medicare cost report, the D4 worksheet, which actually just shows each revenue line item and also the organizational costs for that particular line item. And then usually there's an invoice which just reduces each line item to cost so that the facilities can pay that. So how do you keep track of all this? Create a worksheet for your tracking. You want to track, did you bill for your donor? Did you receive payment for your donor? Did you receive an invoice for your recipient's donor? Did you pay the invoice for your recipient's donor? You want to follow who the contact is. You want to indicate what registry it is and what chain it is, and etc. So these are all the things that, again, you want to be able to track, because as you do more and more, when you're doing one, it's easy, but as you continue to do more, you want to have a very organized and cohesive process so that you can follow through. So here's just an example of one of our tracking sheets where we have the patient's information. We show the recipient's name, who our intended donor was, who's the paired donor, and we just kind of go through the registry, etc. So you can see how we just easily track this in a simple spreadsheet. So another thing that you would want to bring forth to your administration is managed care contracts. Check any insurance contracts to see if there's additional exchange costs that need to be considered. For example, in the National Kidney Registry, charges for the exchange fee are not allowable on the Medicare cost report. But there are some costs that are allowable, such as if your OPO charges you and there's any transportation costs with respect to that. Here's sample language also that you can work with your contracting department to have some of your global contracts reimburse you. So we approached our major payers and we wanted to ask them, we are not looking to have additional costs added to our reimbursement. However, can we have this as a pass-through cost? So they were agreeable. Here's examples of two language. So one of our contractors allowed us to have the stipulation that paired organ donation matching fees will be paid at invoice cost. A copy of the invoice must be submitted to the insurance company. So they were very willing to absorb the extra cost that we were going to incur. So here's just reference. In April of 2016, there were additional CMS KPD guidelines that came out for your reference. And essentially what it is saying is that in a KPD exchange, once the donor is matched with a recipient, any additional tests requested by the recipient center are billed to the cost at the recipient center. So in translation is the donor is your donor until the part that the donor is matched with another recipient. Many centers work up their donor fully and enter them into the exchange and essentially the registry exchange, and essentially they maintain that donor until they're matched. The only time once your donor is matched and the recipient center decides that they want additional testing, at that point the recipient center would pay for that. But prior to that, you can keep all those costs, you put it into your cost center, and you treat that donor just as you would any other living donor. So there's a lot of consequences if you don't follow this, so it's highly regulated. There's financial liability in terms of center financial loss, denied claims, unpaid recipient and donor bills, and potentially collection notices and activity. There could be legal liability in terms of fines and surveys. And again, we don't want to have any negative program reputation. So lessons learned: start a policy, create it, perfect it, but don't neglect it. Follow your flow. When you deviate, sometimes you miss a step. Create tools and use them and checklists to kind of guide you through the process. Perform a postmortem after each KPD. It doesn't have to be long or formal meeting, but reviewing really helps to determine what the best practices are. And track your experiences. Use a spreadsheet or a database. It's easier to track ongoing rather than to go back and try to capture. And with that, I'm providing my contact information here. It's also, I believe, going to be furnished later. And I'm going to turn it over to Marie, who will talk about the clinical aspects. Marie?
Hi. Thank you, Andrea. So now I'm going to shift gears a little bit and talk about some of the clinical aspects that will help you succeed in KPD. This first slide really, I think, reiterates exactly what happens sometimes in KPD that causes the center to have so much trouble, is that they look at it as another living donor transplant. And I'm sure for many of you who have worked at kidney exchange, you realize it's not just another living donor transplant. Sometimes I get calls from another center's coordinator wanting to start KPD, and when I talk to her about the aspects of it, I would reiterate that it's clinical, it's administrative, it's finance, as we just heard some very detailed information from Andrea, and of course you need your lab and OPO support. So when you're embarking on a KPD program, it's important to look at it as a complete new program that your program is entering, and to bring all of these experts around the table to sort out all the things that you will need to make it successful. One thing that we've known early on in KPD over the years is the importance of the KPD Coordinator. And this is a nurse who will be an expert at KPD, and many centers have one with a backup when that nurse is on vacation. But it's very important that to have successful KPD, that the transplant team buys in to KPD. And I think over the years, as we've seen it become very successful, this is less of an issue when transplant centers realize that they can increase their living donor volume by starting a program. But one coordinator does need to become a KPD expert in dealing with internal matches and national matches, and of course have a backup. You also need a dedicated physician or surgeon who supports that nurse and works closely on the program. FTE time for an RN needs to be dedicated, and my estimate is a half of FTE for an RN and a quarter for an assistant as you're initiating the program, but this may grow to a full FTE. We have recently added a full FTE for KPD after many years of trying different approaches of kind of dividing it among living donor coordinators. And this past year we conducted 36 KPDs. So I think that definitely warrants a full-time nurse. So I wanted to just go in very briefly to some of the newer UNOS policies that came out. I'm sure many of you are familiar with Policy 13, which is the kidney paired donation policy, but about a year ago, in December of 15, we were required now to have some new requirements. So one of them I wanted to point out was that there's additional requirements for non-directed donors, that there is, in the new KPD requirement, you do have to put in significant documentation into your medical record when asking someone if they're going to be a non-directed donor. You have to document that you've educated them to all of their options, that they can participate in KPD, that they can donate directly to the wait list. And if you perhaps only do, let's say, internal KPD, but your center in your service area does national matching, you have to document that you educated the donor, the non-directed donor, to that option as well. And that does need to be documented. In addition, and I'm just pointing out, I'm definitely not pointing out all of the new policy, but just some of the things that I think stand out, is that UNOS requires, if you're participating in KPD, that you educate the patient and you have a policy for a broken chain. Now, what a broken chain is if the donor donates and the recipient does not receive a kidney in that match. Now, if you do not have a remedy, then you can simply educate the patient that there is no remedy. What we have done here at Barnabas is in our non-directed donor policy, in our allocation policy, we have noted that we can allocate a non-directed donor to a recipient who did not receive a kidney in a broken chain. So I think that's something important for your team to discuss and how you would want to go about that. So UNOS does have quite a few requirements for informed consent now that you can read in the policy, but I wanted to just go over some basic tenets that I think are important to include in any KPD education, whether they're required by regulatory means or not. So some of the basics are to review ABO and HLA incompatibility. I always start my education talking about the incompatibility of this pair, and what HLA incompatibility is, so that they understand why they're with you. And they may understand then, if the donor is an O and the recipient is O, if they're HLA incompatible, what that would mean. What simply is an exchange, and what are the exchange registries that you participate in, what you would estimate the time to find a match would be based on their incompatibility, and how it works, the steps, the cancellations, the disappointments. If you participate in national matches, I'm sure you're familiar with matches getting canceled, and I definitely take patients through this step because they have to trust me. And if they're not anticipating a cancellation or a postponement, then they may lose trust. But if I tell them ahead of time this happens, that tends to build trust between us. We talk about anonymity. I talk about safety measures. I spend a good amount of time on couriers, if a GPS is going to be used, logistics, because I am going to talk about risks. And this is required by UNOS policy to inform the patient about what would happen if the donor donates and the recipient doesn't receive a kidney. So this is maybe where you want to insert your remedy for a broken chain. And that I do point out to a person that there is no guarantee that their recipient will receive a kidney in exchange. So you could see that education in a KPD setting can take 60 to 90 minutes. And what I do is we have this done towards the end of the donor and donor eval, and I include the donor and the recipient together if it's appropriate. So now I want to move to summary of steps to an exchange, and I've highlighted two of them in orange, but I do want to I am going to go back to identifying the incompatible pair as a point that's very important. So you can see that your education step is very important, so your pair is prepared to go on this journey with the transplant center, because finding a match can be difficult, and then sometimes being in a national match can get canceled and reissued. So that pair needs to be educated for what to expect. Of course, you need to consent according to UNOS policy and your own center policy, and you need to verify and maintain the health status of your donor and recipient. I'm going to talk about that in a little while, but I've listed the rest of the steps, and I think it's important as a center to outline these steps as a team and be prepared to follow through with them. It may help you form your own pathway for a donor and recipient through an exchange. So identifying and tracking pairs may seem initially not complicated, but I found that it's essential to keep track of your incompatible pairs. In a busy transplant center, it can be hard to do that. So a couple things that I'd like to point out. What we do here is that when we first meet candidates, we do a lot of early and repetitive education on our alternative programs, and we call our alternative programs KPD, Incompatible Transplant. We have another program called Compatible Share, which I'll explain to you. But we want recipients to know, or candidates when we first meet them, that incompatible does not mean goodbye, because we know about a third of the recipients we meet who bring forth donors will be incompatible. So you want to educate recipients to this alternative program at their initial visit. And when you're educating a donor, you want to educate them to all your programs. And your nurses who do this education will get very comfortable when they're educating all patients to all programs. Especially the living donor coordinators emphasize to donors when their recipient is sensitized to anticipate KPD. We don't want people thinking it's quote, quote, the booby prize that, they didn't match. We want them to know, okay, it can be common that you don't match, but we have this very successful program that we want to talk to you about. So you get a lot of buy-in, because as you do KPD and you realize it is very successful, you're going to feel very authentic saying that to a pair. And then what we do towards the end of the donor evaluation, we bring both donor and recipient in for an intensive KPD education. That's maybe where we draw blood for cryopreservation, etc. And you need to also keep a record keeping of these pairs. So we meet once a week just to talk about our incompatible pairs and the status of them. And this is just some more information about tracking an incompatible pair. One thing I want to point out on this slide is that it's very important that the person calling the pair to explain their incompatibility truly understands the incompatibility, especially if it's HLA incompatible or there's donor-specific antibodies, because if the pair gets a confusing message, they may become frightened of going forward. So you may have a designated staff member, a designated staff member, if not a physician, call them if the compatibility is complicated and the transplant coordinator doesn't feel that she can explain it thoroughly. So I'd just like to move on to the flow of a living donor. So you can see in this little schematic we have the recipient evaluation, and if there's no living donors in our center, they go to a pre-transplant team for listing that recipient. If they have a living donor, then we have a recipient coordinator on our living donor team, and we have living donor coordinators. So then we're judging, is the pair compatible or incompatible? If they're compatible, they're going to go on to our compatible share program, which I'll explain momentarily. If they're incompatible, we're going to look at what the incompatibility is, and then we're going to decide with our KPD coordinator at one of our incompatible meetings, are we going to list them nationally? And we do participate in 3 national registries, or are we going to match them internally? So I think I'm just going to pass that slide. So when you're looking at national matching, you have different scenarios. If you've not done a KPD in your own center, I would recommend that you do a traditional paired exchange, which is in the purple, which is a 2-pair exchange. Some centers want to only do national matching, but if you've not done a KPD before, I highly suggest you do an internal 2-pair to get your operating room and your recovery all used to the idea of KPD. And then you can move on to a larger, complex national match. And most national matching now have to do with chains, which would be on the right. which typically is started with a non-directed donor and then may have several bridge donors along the way. So we match with several large registries, and why would we do that? Many transplant centers just work with one registry, but over the years we found that we do know that registries don't match databases with each other. That has become a standard. But different registries offer our patients different opportunities. We know that National Kidney Registry does have advanced matching tools on their website, which allows us to look for incompatible exchange. We do ABO and HLA incompatible exchange. They offer more logistical support and GPS with matching. But APD and UNOS are terrific registries to use, but we know what services we will receive from them. But the reason to use multiple registries is when you have your high PRA recipients. And we found great success in registering with multiple registries to try to help our high PRA recipients receive a transplant. In addition, recently we started using an internal KPD matching software, and this may be utilized for payers that do not want to participate in a national match due to not wanting to receive a shipped kidney and the risks that you need to explain to them that are required by UNOS, or if you're using more compatible pairs, and I'll discuss that. This is a list, because we match with multiple registries, our OPO, which helps us with our data, has developed this registry listing form. And I can share all these tools with you, but it really helps when we're laying out the donor and recipient information. So each sheet is one is for recipient, second's for donor, and it helps us document everything that has to be put into the registry, the 3 registries that we use. So let's talk about some KPD rules for activation. I think that the first rule, that the recipient and donor are truly cleared and available, is probably the most important rule that you can follow. I've seen many matches fall apart because when the pair was actually listed in the registry, something was missing. And then when they came into a match, when the other center reviewed that donor, they came across something that they wanted or that they didn't feel would be cleared. So I can't emphasize enough to double check your donor and recipient charts, audit them to make sure that they're truly cleared and available and that their workup is up to date. In addition, you have to know if your payer is willing to accept a shipped kidney, that they understand the risks and benefits. Also, what age donor is your recipient willing to accept? You want to know that before you do pre-selects in a registry, because you don't want to get into a match if the donor is older than the recipient is expecting, and then to find out that you have to pull out of the match. And other donor characteristics. This is all very important to discuss at the KPD education, because you're working for your payer. You want to explain to them what is possible. If they do have stricter criteria, that they're adding wait time. You know, sometimes recipients feel, well, my donor's 28, I want a 28-year-old kidney. But then that's fine, but you just have to explain to them that they're adding registry wait time. And when everything is balanced and explain to them, they may understand that that's not the most feasible thing. So in going back to my first point, it's very, very important to audit the donor and recipient chart before KPD activation. I can say that you're probably going to avoid 70% of the misery of KPD if you actually do this, and you don't want to cause a swap failure. And this is an audit sheet that we developed here, which we use, and we're happy to share it with all our donor charts. We used to score them as part of a QAPI process for our living donor coordinators, and the living donor coordinators really liked another person auditing the chart to make sure that they weren't missing anything, and we utilized our transplant NPs and a PA to audit the donor charts. And sometimes they do come back because they're looking at the whole picture, and they may want additional testing or request a consultation. So who matches easily in exchange? Well, we surely know that A recipients and PRAs lower than 90 are easier matchers. And why is this? The most common ABO incompatible pair you will meet will be an A donor and an O recipient. So there's many, especially in the national registries, you're going to find many A donors. If you participate in the National Kidney Registry, you may once in a while get an email saying that they have A donors ready to donate. So please list any A recipient. So you have an A recipient with a lower PRA, you can expect them in any registry to be matched quickly, even if they have an AB donor, because sometimes that pair will be put on the end of the chain and the AB will be given to the wait list. So just some other lessons in KPD matching is that easy matchers would be A and B. So if you have an AB, BA mismatch, you're going to find them an easier to match, and a lower PRA. Typically under 90, even maybe under 95, you will be able to match them nationally. Difficult matchers are always O recipients, and of course any high PRA. In that case, if your program is doing incompatible, you may consider an incompatible exchange, because you may be able to find a national donor who is less quote-unquote incompatible than the current intended donor. And in national registries, you're exposing your pair to hundreds and hundreds of donors, so you may be able to find that match that you couldn't internally. So I've been mentioning our compatible share program. This is a program for compatible pairs who may want to participate in KPD. This is a lot of discussion around the country about asking compatible pairs to match. And why would they want to do this? To receive a younger donor kidney or an improved HLA match. And many pairs do very much like the altruistic opportunity to help incompatible pairs. Many compatible pairs don't even realize there's incompatible pairs. I know that seems illogical, but why would they know? And if this also is a very difficult program in some ways to operationalize, because you have to look at how does the transplant center staff feel about this? Are they comfortable? And how you track these pairs, because what's very important to a compatible pair is that they don't wait. So you have to accommodate their time frame. So you have to be ready when you have to identify the compatible pair early and approach them early in the process. And if we always approach the donor first. If the donor is interested, we will discuss it with the recipient, and then we will talk about that we would not delay their transplant in any way. So I just wanted to talk a little bit about what a bridge donor is. So a bridge donor donates after their recipient has received an exchange. And as I mentioned early on, there is requirements now for bridge donors in the new UNOS policy that needs to be documented. So it's just good to read through policy 13.4E to understand the medical record documentation that you have to do when someone becomes a bridge donor. And there's many philosophies about identifying a bridge. Very often in conferences there'll be a case study or questions about who can be a bridge donor, and many times it's not anything scientific. It has to be a gut feeling about the donor and the recipient pair and how long you would have that person be a bridge. Many of the registries have a time limit for bridge donors. NKR is about 3 months. I know APD has very, very comfortable with bridge donor. So it has to be a center philosophy. But we believe that if you're going to ask a donor to be a bridge, that should be an in-person discussion. And you should also have it, if the donor wants to renege after their recipient has received, you have to discuss with the transplant team how you would handle that person. But I think bridge donors should be used minimally, and they should be a person that can handle the wait and the anxiety perhaps of waiting. Some pairs, though, do prefer it. For example, a spouse may think that that's terrific because she can be with her husband when he gets transplanted, and then later on, several weeks later, donate her kidney. So some logistical decisions that you want to think about is factors to consider when reviewing matches is, let's say you're in a national match, you want to look at the registry, what logistical support is offered, do you have a GPS? You want to use a courier that's experienced in transporting living donor kidneys. Sometimes I'm going to match, they will give you an option of which courier to use. You want to use a courier that is very familiar with KPD and the communication that's needed. You want to look at where that donor center is located, so what is going to be the cold time on the kidney? Is there a direct flight? Would you have to use an onboard courier? Onboard couriers are used when the flight, you only can receive a connecting flight, so that person stays with the kidney throughout the whole from one flight to the other, and what is the ground transport time. So you have to think a lot of different things when you get a match offer. And also some of the logistical safety when you're shipping a kidney is that the courier, because they're experienced, they know how to maintain a chain of custody. They will obtain a lifeguard status for the flight so the airline knows that there's a kidney on the plane and will get priority. Is there a GPS available? Very important to find out who the preservationist is packaging the kidney. It should be an experienced person who knows the requirements of packaging kidneys. These are just some of the things that are required to be in the kidney box. You can look through that on the UNOS policy. And this is a form we created several years ago that what you use this form for, and I'll be happy to share it, is your preservationist confirms that everything is in the kidney box with a OR staff member. So you're making sure that what goes in the kidney box is required, because it's essential that when the kidney arrives at the recipient center that the paperwork and the required paperwork is in that box, or the kidney will not be able to be used. So this form, we keep it at our center, but it is required to be filled out. So just some last thoughts on support. It's very important if you're starting KPD or you're ramping up your volume is to meet with your OR and develop rapport, you may want to, I definitely in-service our OR occasionally. You want good communication. You also want to bring in your pre-op and your PACU staff so they understand that patients may need to be separated in different bays post-surgery. And what is your preservationist support? Our preservationist comes from our OPO. We have a system for booking the preservationist, and we understand what they are going to bring and the paperwork that we're going to provide. And you also want to discuss with the donor center that you're receiving a kidney from what preservation fluid they're using. Is that acceptable to your surgeon? Will there be minimal bench work on the kidney? And of course, who is packaging the kidney? So just some ideas to think about outside of the transplant center in the other hospital services that you will need. So I'd just like to turn over the presentation now for any questions.
Thank you so much, Marie, and both Marie and Andrea for a fantastic and very thorough presentation. Just as a reminder for all of you who are participating, if you have questions, on the bottom left-hand corner you should see a little blue icon. See where the red arrow is pointing to. If you click on that blue icon, you can enter your questions for the speakers. And then as those questions are coming in and we're addressing them, if you can also, if you are participating in a group today, please be so kind to complete the poll, how many people are in your group. And so we will leave this poll up for the duration of the Q&A so that all the groups can complete it. At this point, I'll turn it back to Debbie Mast for the questions.
Thank you, Hetty, and thank you both. That was a wonderful presentation. So while we're waiting for questions to come in, what are the three key takeaways or action items that you'd like people to be able to take back to their centers, both for Andrea and Marie?
So I'll go first. This is Andrea. The first thing is to set up systems. Make sure you have a process for billing your donors, posting receipts, understand your Medicare cost reporting, and understand your contract language. Know what is needed for each registry because the process is different. And don't forget to assess and financially clear your matched pairs. I will just mention that Marie spoke about remedies. One other takeaway would be that you should always have a backup recipient at your center, or backup if you're getting a donor kidney, and make sure that that backup recipient is cleared, because if there's a remedy that you're going to be using that donor kidney in the event that your recipient is for whatever reason not able to be transplanted, we don't want that donor kidney to ever be jeopardized or be wasted or not utilized. So having a backup and financially clearing that backup to be ready to go just in the event that there's an emergency is a great takeaway. Marie?
Okay, some key points that I think are important is to know your UNOS, LD, and KPD policy very well. I can't emphasize this enough. That will really help shape your patient consent and your policy. Another point is that you need dedicated staff and MD time for KPD and to make sure that they're competent in those areas. It's not another living donor transplant, but it's an entire program. You may start off with 1 or 2 KPDs, but to really move your KPD program and increase your volume and help your incompatible pairs, you need to have a dedicated staff and physician who is focusing on KPD. Develop a method to track your incompatible pairs, even if it starts off as a short weekly meeting among an assistant and a KPD nurse to go through incompatible pairs and develop ideas for tracking them. Another point, confirm that the donor and recipient are completely cleared before you enter them into a registry or an internal match, and you may consider an audit process. And finally, this can be very daunting, especially participating in a national match. So it's important to reach out to experienced centers for advice and attend conferences on LD and KPD. As you enroll in a national match group, they will definitely be able to provide you with other centers in that registry who would be available to explain points to you. And I think it's very important to reach out to centers and not feel embarrassed if you have questions, because everyone has questions, and as you do things that are more complicated, it's only natural to want to make sure that you're doing it correctly, because making a mistake can not only affect your patient but any other patient in the match.
Thank you both. I totally agree with that last point you made, Marie. Even those of us that think we know a lot about it sometimes start to question ourselves. So that's actually a wonderful point. So we do have our first question. The question is, how do you keep multiple offers separate using multiple KPD programs?
This is Marie. I'll answer that. So I think the question is asking, if you enter a pair into multiple registries, do they all get matched simultaneously? So what I do in that situation is if I feel a pair is a very easy matcher, I may only choose one registry to enter them in initially for several weeks. And then if they're not matching, enter them in all 3 registries. We use NKR, UNOS, and KPD. But it is important not to, and if you do get a match and you're in multiple registries, you have to have good record keeping and inactivate the pair from the other registries.
Terrific, thank you. I don't show any other questions at this point in time. You guys must have done a fabulous job, and in fact you did a fabulous job at explaining everything.
Thank you so much, both to Andrea and Marie again for your time and sharing your expertise. It was a very, very thorough presentation, so I think that you probably addressed a lot of the questions the audience had. And I also want to thank Debbie for coordinating the topic and inviting Andrea and Marie to present today. Thank you all for your time, and for all of you who attended today, thank you for joining us, and we wish you a wonderful rest of the week. Have a wonderful day. Take care. Bye-bye.